All right. السلام عليكم. إن شاء الله نبدأ. Welcome again to the Taiz Cardiovascular course. واعذروني على الوقت المتأخر عندكم بسبب تعارض في الجدول عندي. إن شاء الله الوقت حيكون تقريبا ساعتين أو أقل شوية. um, so بتسمعوني كويس؟
ايوه، اللي اسمعك ممتاز.
طيب.
ممتاز ممتاز.
لا. So, this is the third lecture. Last two sessions, we talked about PAD diagnosis and some criterias and scoring system. Today, we'll talk about vascular access. And again, these are some of the basics in the cardiovascular medicine field, especially interventional. So this is a very important topic. We deal with vascular access on a daily basis, and we should all be comfortable with that. My hope from today's lecture is to present some cases and to provide some examples of vascular complications from coronary or peripheral or structural cases, and then ultimately provide you with some ways to treat or perhaps avoid these complications. So I'm going to break this down into the top 5 essentials for arterial access, which are understanding the anatomy, and then access is really requiring 3D integration of where the vessel is relative to where you are starting from in the skin. Then you should also always plan ahead so you are aware of or you can anticipate the unforeseen obstacles in obtaining access. And then sometimes it's helpful to use angiography, or I should say angiography or venography, to evaluate ambiguous circumstances and hopefully develop the skills to avoid or escape these types of complications. So I start by saying it's very important to understand the 3D anatomy, and you can use a lot of cues to help you understand where you are trying to go. It's important to use anatomic landmarks, but in a lot of patients, especially who have obesity, it's very difficult to use anatomic landmarks only to get to the vessel where you want to hit the vessel. And sometimes ultrasound and fluoroscopy can guide you to the target. This is just a schematic representation of the anterior superior iliac of the anterior superior iliac crest, and then the symphysis pubis, and then there is the inguinal ligament between them. And the inguinal ligament is the one that divides the retroperitoneum and from the spot where you want to enter the femoral artery. And typically, if you're accessing the femoral artery, you want to be somewhere in the middle or the lower part of the femoral head. So the femoral head acts as a backboard against which you can compress the arteriotomy if you need to, and it keeps you safely out of the retroperitoneal space in cases of bleeding. This is another illustration of where you should hit the femoral artery. And as you see from the image on the left, 90% of patients will have their femoral bifurcation in the middle of the femoral head or below. So most of the time, you don't have to go above the middle of the femoral head. And rarely you have to go above that level to stack the common femoral artery. So the optimal access should be below the inferior epigastric artery, as this is one of the landmarks of retroperitoneal space. And so this is the inferior epigastric artery. So you always want to stick below that. Also, above the inferior epigastric artery, the femoral vessels. If you go above the inferior epigastric artery, the femoral vessel would go deep, and it becomes really hard to compress it in cases of bleeding. And to make the case for micropuncture, if I'm sure you've probably dealt with micropuncture. If you apply the Ohm's and Poisey's law, the flow rate increased to the fourth power of any increase in the radius. Thus, since the 18 gauge needle is about 56% larger than the micropuncture needle. So you will see that there is a theoretical 5.9 increase in blood loss if you have a bad puncture with an 18 gauge needle compared to the micropuncture needle, which is a 21 gauge needle. So currently in the US, we exclusively use micropuncture needle. We almost stopped using the 18 gauge Cook needle, except in emergencies and codes. Obesity is one of the biggest challenges with vascular access. We always say you need to get into the vessel at 45 degrees, but there are always exceptions to that. If you are going at 45 degree, you can somehow easily tell where you start. And so you should be starting here and where you would end by just estimating. And if a person has large habitus, as in this image in the right, you're going at 45 degrees using fluoroscopy to tell you where to start on the skin, you're going to end up much higher than the femoral head, as you see here. So if you stick to the 45 degree, you will end up sticking high. So the angle doesn't really tell you exactly what to do. So you have to use ultrasound and figure out how deep the vessel is. Normally, the vessel should be around 2 centimeter deep, 1 or 2 centimeter deep in average thin patients. But if it's deeper than that, you will need to adjust your needle and make it more steep, which is not the best thing to do. And we will explain the reasons why. So, in this obese patient, if you change your angle a little bit steeper, then you will get into the femoral artery at the level of the femoral head. So that's one way. Another way is to move your needle a little bit lower and stick to the 45 degree, but also you moved your needle to a lower level. Here is a case from years before, and as you can see here, they put in a catheter just outside the body to show you the anatomical landmark of this patient. They just put a catheter just to mark where the inguinal ligament would be they just put it between the symphysis pubis and the iliac crest. And if you just depend on the anatomical landmark, as you see, you would stick really high here. And that's what happened. They stuck really high because they just depended on anatomical landmark. They did not use the ultrasound or fluoroscopy. So if you use fluoroscopy in this case, there's no way you would have stuck the femoral artery this high. But they just examined where the iliac crest is, where the symphysis pubis is, and they stuck right below it, and they ended up too high. So don't do that. Always use assisting tools such as the ultrasound and fluoroscopy. And then the algebra here, if you're going in at 45 degrees, a lot of times we're not just putting the needle in through the skin, but you are also kind of dimpling or compressing the skin. And nowadays you are really pressing down with an ultrasound. So imagine you're putting an ultrasound here and you're compressing the skin here, which changes the anatomy quite a bit. So you have to anticipate these changes. And so the depth here will become much shallower. So think about leading with the angle of the needle tip and where that would be put on the longitude of the vessel. Um, when you use fluoroscopy, just to kind of line things up with a Kelly clamp, a lot of times we use a Kelly clamp just to mark where the lower border of the femoral head is, and then you step on fluoro, but you have to take into account the ways in which you move the patient's anatomy as you're trying to insert your needles in the first place. And here's an example. You put the Kelly clamp to mark the lower border of the femoral head, so you can slightly stick above that Kelly clamp. And the real anatomy is very different from where you put the Kelly clamp is. And so notice here when you're pushing with your hand, all that pannus or the fatty tissue, as you see here, this dark space here is all fat tissue. And so if you push it with your hand, you notice the Kelly clamp will go up much higher. And that's what happens usually. You mark where the Kelly clamp is at the lower border of the femoral head, and then you take your needle, and then you push with your left hand all that pannus, all that fat, and then you put the needle, and you end up being very high. And so this is why it happens, is because you are marking the anatomy before you push your hand, and then you put the needle while pushing your hand, and you move all that anatomy up. Here's another case of a patient who had a huge pannus, and as you see here, this dark tissue here, this is all fatty tissue from the abdominal pannus. And notice you can, if you don't move, like, let me stop this and just show you here. If you don't move this adipose tissue up and you just put your needle at the femoral head, at the lower border of the femoral head, you will end up going through all that adipose tissue. You will go through the skin, you will go through the adipose tissue, and then you will go out of the skin again, and then you will go in again to the skin again. So you will go through multiple skin folds if you don't move that pannus up. So what you have to do, and what I always do with obese patients, is I push the pannus up before I do anything. That's the first thing. And then I put the Kelly clamp, and I do the fluoro. I mark with a marker or a pen, a sterile pen, where the lower border of the femoral head is, and my left hand is pushing the pannus the whole time. It's not moving. Or if I'm using an ultrasound, I'm pushing with the ultrasound the pannus up the whole time. And then I move my hand and I use the needle with my right hand, and so that the anatomy does not change on you between marking things and between doing the access. Another thing that I haven't heard of being discussed a lot is what we call parallax. And if you have a cath lab machine with a floor-mounted C-arm, and you are trying to get the patient's head up as close to the C-arm as possible, you're trying to raise the table up so that you can see the Kelly clamp. And moving that C-arm up, it can change the angle of where the Kelly clamp is. And you should always be careful, because the Kelly clamp here in relation to the femoral head is changing as you are moving the fluoro. As notice here where the Kelly clamp is and how far it is from the femoral head. And notice here when I move the the camera up, you notice how closer the Kelly clamp came into the femoral head. And in reality, the truth is the Kelly clamp is a little bit far from the femoral head. So always what you need to do is you need to move the C arm to the side, and I'll show you here. So here is an example of what I was talking about. If you are really low down and not centered on where that collimator and that detector are, the Kelly clamp really kind of moves relative to the femoral head. So take that into account. It's sort of like if you are shining a flashlight, you know that the Kelly clamps here relative to the femoral head would be much higher. So the Kelly clamp here, if you put the camera here and you shine the flashlight a little bit in an oblique angle, you will see that the Kelly clamp is above the femoral head. But that's not the reality. The reality is if you center your collimator right below the femoral head, the Kelly clamp is in the right position here. And so, as I said, move the C arm to the side of the bed. You know, these cath lab machines, you can move the C arm to the side, and you can center up your image where you have your Kelly clamp relative to the femoral head, and use that as your anatomic landmark before you stick. You know, when you don't use ultrasound and you feel the pulse with your fingers and want to bring your needle into the artery, it's always important to line your fingers up in a line, in a straight line, and you need to think that you're moving your needle like you're painting a stripe into the artery. You're not coming in from the side. You need to come in a straight line. Similarly, also, if you are using an ultrasound, never access the artery from the side. You need to center your ultrasound on top of the vessel and insert your needle from the center rather than from the side, because you can still get into the vessel from the side, but it becomes really hard to close the vessel afterwards. And so this is another illustration. You should always come from the center. You should never come from this side. Like a lot of people would angle their needle and they would still get into the vessel, but closing it becomes really hard, and the vessel would keep oozing or bleeding throughout the case and becomes a mess. And we describe it like if you're flying, you know, a fighter jet, and you're trying to land on an aircraft carrier. You cannot come from the side and then just make a right turn when you get there. You have to always line it up and then come right on the pad from there. Ultrasound can help us tremendously. This was the Faust trial that was about 15 years ago, big trial. It showed us that our cannulation it shows us that our cannulation rates can improve. You can avoid sticking the vein when you are aiming for the artery, and it did not really change the time needed to get access. A lot of people think about ultrasound as it delays them, and in reality, when you get used to ultrasound, it really saves time and you become more efficient using it. You know, when you're learning ultrasound, you have to integrate in your mind where you are pointing the ultrasound probe. You have to know that the ultrasound probe is pointing downwards here, and understand where the needle is relative to the probe. And what I find most often is that folks may be bringing the needle in and missing where the tip of the needle is. So if you put the needle here, you will only see the needle under the ultrasound at one point only. So if you come in, you won't see the needle, you won't see the needle, you won't see it until you come here, then you will see the needle. If you are still away from the vessel and you keep going, you will miss the needle, and then you will end up sticking much higher. And in this case, really, the ultrasound did not help. And what other people also do mistakenly, this is a very common mistake, is they try to chase where the needle tip is. And so if you start missing the needle tip, they start tilting the ultrasound sideways or in an oblique angle so that they can keep watching it. And it really did not help you. What you need to do is keep the ultrasound straight and in a straight angle. And if you go in an angle and you start missing the needle here above the ultrasound, you need to adjust your needle, either stick lower and then you come in here and you will see the needle right above the vessel, or you can stick in the same place but just come at a steeper angle, just like that. And steeper angles are not as safe, but sometimes you have to do that. Um, Most people nowadays will use micropuncture and then will use a micropuncture dilator or sheath to take a picture. And I think that's really helpful before you upsize to a bigger sheath. So you do a micropuncture sheath. The micropuncture dilator is about 3 French. So 3 French is very small. And as you see here, this is the micropuncture, and you take a picture. But always ensure that you have a wire through the micropuncture. If you don't have a wire, you will cause dissection and injury, and we'll talk about that later. Sometimes I've seen people simply use the inner dilator of the micropuncture, and we do that sometimes, but just because we're trying to be efficient and fast, but this can be harmful, especially if you use a micropuncture kit. It's called a stiffened micropuncture. It's a stiffer catheter. It has a stiffer tip, and the tip of the dilator, as you can see here, it's hitting the wall of the vessel. And if you inject contrast against that vessel wall, that intima will always get disrupted, and you will cause dissection. And so always use a wire inside the micropuncture dilator to protect the vessel from injury. And I'll show you some examples here. When you have one of the things we do or one of the things we see when we do peripheral cases, or even we do structural and coronary cases, we sometimes see retrograde dissection. And as you see here in this area here, there is a dissection here. The good thing is, if you have a dissection, it's usually retrograde. So the dissection happened when you were trying to go up with your catheter, and the blood flow is against the dissection. Unlike when you do the coronary dissection, the coronary dissection is not as forgiving as peripheral. So the blood flow is against the dissection, and that's what we call retrograde dissection. And so usually these types of dissection, they heal on their own. And so we manage them conservatively. Do not take a sheath angio of any sort without a wire up. And I mentioned that earlier, because the short sheath that we use usually is about 11 centimeter. And a lot of patients, they start turning into an external iliac from the common femoral in around the same height. So the sheath is coming this way, and the tip of the sheath is hitting the wall of the vessel here. And when you are injecting contrast to take a picture of the access, it's almost like you are shooting a rifle, or it's like a bullet coming out of the sheath, and it causes hydraulic force with the contrast and causing dissection. So just if you put a wire in throughout the vessel, it will kind of neutralize the sheath away from the walls, and will prevent dissections. This is like a worse case where it needs to be treated. As you said, dissections usually are forgiving. You don't have to treat them, but up to a certain extent. If you have a big dissection, you need to treat it with a stent, and this is what happened in this case. They did an injection, and as you see, the tip of the catheter is here, and you injected the contrast, and it disrupted the whole intima and caused the dissection, and so you ended up stenting this. Where when you're getting micropuncture access, you can sort of cause distortion of the skin and fat between where you're going in and where you're hitting the artery in a way that might bend the needle, and therefore you bend the wire as you're going in. So it's like a dimple. So you go in this angle, and then you release the pressure from the ultrasound, and then the adipose tissue goes back up. And what happens is the wire gets bent, and it causes almost like a zigzag shape. Um, and this is how the catheter will be sitting throughout the case. And there's going to be a lot of oozing from here because you're kind of pulling on the arteriotomy the whole time. And the reason this happens again is that adipose tissue, you distorted it initially with the ultrasound, and then you release that pressure, and then the wire, because it's a flimsy soft wire, got distorted. And so what you have to do in these cases, you always have to anticipate these obese patients. Is you either go in lower, and that's probably the best thing to do in these cases, instead of pushing all that adipose tissue and then changing the anatomy afterwards. This is an example with an Impella case. A couple of times I've seen this a lot. When you use that subsequent pathway for a large bore access, and as you see in this picture, you can see the wire is kind of backwards. It's going this way, and then went into the artery, and so that kind of formed like a Z shape, and that's how the impella is sitting the whole time. Imagine a big sheath is sitting like this, and it's pinning the vessel open, and you have a lot of bleeding from here and from here. And instead, the sheath always should be sitting smooth like that. And so we were asked to take this patient to the cath lab because to close the vessel. And as we are trying to exchange the impella sheath, and we took everything out, and you can see the sheath how the zigzag shape is. It's horrible. And you are trying to trying to put in a 14 French sheath and figure out what to do next. We exchanged everything over a wire, and you can see it's like cramped on itself, and this was a problem as we are taking pictures, and we ended up this is the picture here, and what we found as we were trying to and this patient, we could not control the bleeding with the catheters and closure devices, and we just had to put a dilator inside the sheath to stiffen the sheath and get rid of that Z shape. And as you see here, the dilator, and we left the wire up as well, and the patient had to go to the OR for closure, as we could not use any type of closure devices, and what manual compression was futile because the patient was bleeding the whole time, and as you see here, a big hematoma. But another way, if you don't want to go to the OR or the patient is not stable, you can always stick the other side with a smaller sheath, and being more careful, you can go to the left and go in with a 7 French sheath and use a destination sheath up from the iliacs, and then basically use a balloon to tamponade that area. That's something we we would use. It's not always successful, especially if the arteriotomy is very big, but you can reverse the heparin and balloon every 5 minutes and then deflate the balloon and then repeat that multiple times. A lot of times you can control it as well without having to go to surgery. Just a couple of thoughts about micropuncture, which is clearly our standard of care nowadays, but just you have to be mindful when you use micropuncture because it can give people some sort of false sense of security. It's a narrow gauge needle, so you don't get quite as much pulsatility or pulsatile flow from the back of the needle to tell you that you are in the vessel. If you use the bigger needle, the 18 gauge needle, you go into the vessel, you will see a lot of blood gushing back. But when you use the micropuncture needle, you don't see a lot of blood, or at least you don't see as much of pulsatile flow as the 18 gauge needle. So I'm mentioning that because if you go into the subintimal space in the vessel, in the artery, and not inside the true lumen, you will still get blood back. But you are not in the true lumen. You are either in the anterior wall of the vessel, or you are on the posterior wall of the vessel, and then you end up advancing your wire. The other issue with the micropuncture kit is the wire is very flimsy and it does not have that tactile feedback. So if you are pushing it through a subintimal space, sometimes you don't feel that. Or at least it needs some experience to feel that the vessel is not free. So the key here is if you are not sure where the vessel is, always advance the micropuncture wire under fluoroscopy. So if you're doing a bedside procedure without fluoroscopy in the ICU or something, and it becomes problematic if you are not sure if you are in the true lumen, because you end up putting the bigger sheath in the subintimal space, and you end up dissecting the whole vessel. This is an old image. People just don't even do that anymore, but I just would like to show you the needle is not in the lumen, or sometimes the needle is not in the lumen, and sometimes people just want to check and they end up injecting dye or contrast through the needle. And if you are in the subintimal space, imagine you are injecting contrast through a sharp needle in the subintimal space. So you will cause a big dissection in the vessel. So and this is what happened in this case. They just wanted to take a picture, I guess. And you see here, all of this is dissection. This is not a normal blood flow. This is all contrast in the subintimal space going into the SFA and profunda. Patient ended up doing fine, again, because this is a retrograde dissection and the antegrade blood flow took over and the patient was okay, but it's not always like that. This is another really bad case, where folks were not really sure where the micropuncture wire went. And so after they put the wire of the micropuncture, they put the dilator. And then after they put the dilator, they put the 035 wire, the bigger wire. And they noticed that the 035 wire was having resistance at the terminal portion of the abdominal aorta, and so they put in the sheath, and then they took an angiogram. So they did an angiogram after they put the sheath, and the sheath is in the subintimal space, and it's not in the true lumen. So here, number one is you can see you've caused a big dissection. Number two is, as you notice here, there are bubbles here because you're not able to aspirate, and then you end up injecting, and you're injecting some air, and so you can see some air here. And the third thing is, when you see a fluoroscopy like this and the patient is moving, especially for peripheral cases, that's usually not a good sign because the patient is in a lot of pain and they're just moving during taking the picture because you dissected the whole vessel and you injected air as well. Air is painful and the patient was moving. So these are three bad scenarios. You can just be careful and avoid all of these. Here is another one. The micropuncture introducer was inserted, and they took an angiogram, and this is in the inferior epigastric vessel here, and this is the left groin. So as you see here, the inferior epigastric and the micropuncture sheath is either right next to the inferior epigastric, and they stuck right next to it, or maybe the micropuncture needle was inside the inferior epigastric artery. And it's not a big deal. This is a micropuncture. It's a 3 French or 4 French. You can always pull it out. And that's what they did. They pulled it out and they held pressure for a little bit, especially if you're not on heparin, you should be okay. And so abandon that and restick at a lower level. For large bore access, especially for structural procedures, or if you're using mechanical supportive devices with balloon pump, balloon pump is not that big, but if you're using Impella and stuff like that, you always have to think about using a supportive wire. This is a patient that had aortic stenosis. They wanted to do balloon valvuloplasty. They went through the right groin and they used the J wire. The J wire is 035, and they used the 11 French sheath to deliver the balloon for the valvuloplasty. And so, and this was just amazing tortuosity. This is the whole femoral and iliacs, and then going up to the aorta. And we see this quite often here, especially with advanced age in the 80s and 90s. And so it's a lot of curves and in the iliacs. And the problem with this case is instead of changing this into a more supportive wire, they decided to advance the 11 French sheath over this 035 regular J wire. And at the end of the case, the patient got hypotensive. And this was the picture they took. And as you see her here, it looks like the vessel is corrugated almost because they have straightened the curves. And there was a point here of laceration. And as you see here, there's some bleeding here. And what happened most likely is when you go up with a sheath, 11 or 12 French sheath, over a flimsy wire, the wire is not supporting you, and you end up hitting this sheath and digging it into the wall of the vessel, and you end up causing a big injury to the vessel. While if you used a stiffer wire, sometimes you can use Amplats extra stiff. There's Amplats super stiff. There's Confida wire. There's Linderquist. All of these are supportive wires. They're the same size, but they straighten all that tortuosity that you saw earlier. And so when you go up with a sheath over a stiffer wire, the sheath will not injure the vessel, unlike when you use a softer wire. So always think about using stiffer wires with tortuosity. And so the first thing is we balloon that laceration, and always think about ballooning. If you see laceration, always think about stabilizing the bleeding and tamponade that extravasation, and then you can think about what to do next. You always have time to think about what to do next, but you have to stop the bleeding. If it's bleeding from outside, you can always use manual pressure, but this is bleeding in the pelvis. And so you can stabilize the patient, give them pressors, atropine if they got bradycardic, and then look around in the cath lab what equipments you need, and get your emergency supply cart around, and then Eventually, we had to do stent here, covered graft self-expanding stent, and was deployed right there. And this is the final picture. You can see how the laceration sealed effectively. And as you see, it's nice that they did not cover the internal iliac vessel. They just landed the stent a little bit distal to the internal iliac. So lessons learned from a case like this is first, when there is a catastrophic bleeding, just get hemostasis. Always think about hemostasis, ballooning, manual compression, and then ABCs, emergencies. Is the patient breathing? The airways are protected? Do you have enough venous access? And do you need blood? All of these things, and always take a deep breath, think, and always ask for help if you need. That's something you will, as you practice in the interventional field, you will face a lot of complications. You will be humbled by the amount of complications you see. No matter how experienced or how big you are or how famous you are, you will always have complications. And this is kind of a culture we have in the US. If we have a complication, we have our colleagues from the other cath lab will come in. They will just stand with us, support us, and think with us. And so this is kind of a culture that you have to create in your work environment. And then at the end, reflect. And this is what we're doing here. We're reflecting into these complications and how to prevent them in the future. Vascular tortuosity, what I would say is if you see super tortuous vasculature, as we saw earlier, I think start with a atraumatic wire before you go up with a stiff wire. Go up with like a woolly wire or a glide wire with a soft tip, and then use the wire all the way up, and then use a smaller flimsier catheter like a glide cath and go up all around these curves into the aorta. And then once you go up to the aorta, then you can exchange the soft wire with a stiff wire, like the Amplats and Linderquist and all that. And then you can go in with the sheath over the stiffer wire. And remember, when you have a tortuosity, do not use a short sheath, because the short sheath is, remember, it's it's about 11 centimeter long. All these short sheaths. And so if you have tortuosity, you have to use a longer sheath. There's a 25, there's a 35, there's a 45, 65, but mostly you need a sheath that's about at least 25, 35, so that the tip of the sheath is here, so that when you advance balloons and wires and stents through the sheath, you don't have to hit these tortuosities throughout the way. It's almost like bypassing the tortuosity. Here is another case with a laceration. As you see here, there is a bleeding here. And this is a patient who underwent a PCI. Afterwards, he became hypotensive, and you can see the laceration here. And this is a very small branch. And so this is the bleeding. The bleeding is from a smaller branch. I'm not sure if a wire went through here or something, but this is the branch, and the bleeding is from here. And if you see also the bladder, the urinary bladder should not look like this. The urinary bladder should look like this. And so something is pushing the urinary bladder and making it look like a crescent shape, like a hilal. And so that shouldn't be there, and you need to stop the bleeding. And here is like a close-up, a very close image, or a magged up image on the lacerated vessel. and these are tricky. These bleedings are very tricky because it's very difficult to control it. If you think you're gonna do a covered stent here, you will cover the vessel from here, but the patient will continue to bleed because there are a lot of collaterals from here as well. So these are very difficult to manage, and this is how this patient was managed. Um, Balloon just to stabilize the patient a little bit, although they are still bleeding from the collaterals from here, but at least get them a little bit stable. And then what you need to do is go from the other side, get contralateral access, and this is the sheath that came from the left side, and this is the tip of the sheath. And then what we used is an angled glide cath, and through the glide cath we wired that whole vessel and went through the collaterals. And then you advance the glide cath, and then what you have to do is you have to close the bleeding from above and below. So the bleeding was here, but you had to coil above it, and you have to coil below it. And so you had to go in with a glide cath all the way deep here, deliver coils, and then pull back, deliver coils. And now you stopped the blood supply from both sides of that bleeder. And this is a very common thing that you would see in the pelvic area. These small vessels have a lot of collaterals, and this is how you should deal with them. They're stressful, of course, because wiring this is not easy. Coiling both sides is not easy, but this is how you should use it. This is how you should do it. If you get nervous and you just want to do it quickly and you do a covered stent here, the patient will continue to bleed, and you will end up being, screwed because you cannot coil it anymore because you've covered this area and the patient is bleeding from here. Bleeding around the sheath is another common thing that happens. This is a 6 French sheath, and you can see there's extravasation here. You see the blood here gushing next around the sheath. And so the reason this is happening is the sheath is coming in a very steep angle, almost like a Z shape, as we talked earlier. The sheath should not be coming like that. It should be coming like this, and should be a very smooth angle so that it does not pin the vessel open the whole time. And so what you do in these cases is basically you have to upsize the sheath. So if it's a 6 French, you go up to 7 or 8 French so that it stops the extravasation. As you see here, it sealed it well. And then at the end of the case, finish your case and then close it with a closure device. Here's another case. Injection through the common femoral. What you see here is getting used to seeing bleeding and complications and being nervous about having a complication. You notice something unusual here, as you notice here. And this is not a bleeding. This is actually the peristalsis movement of the ureter into the bladder. And so if you see such a thing, just relax, and it shouldn't be a problem. Another thing we use is called roadmap. This is a feature in the cath lab. A lot of cath labs have that feature. There is a button in the control of the cath lab table. It's called roadmap, and basically roadmap is a dynamic visual overlay. We use it sometimes in the large bore access when we do TAVRs and stuff. What we do is we come from the other side, and we put a catheter here, and then we inject contrast. And the contrast is showing us where the vessel is. And then we don't have to use ultrasound. We just go on fluoro, and this map is showing us where the vessel is, and we just put in the needle in the vessel. This technique is very helpful to stick the middle of the to be able to stick the middle of the vessel. So as you notice here, um, you are sticking in the center of the vessel. You're not coming from the side here or from the side here. You're just putting your needle in the center. And you know exactly where the needle will go into the vessel in relation to the femoral head here. And so we use this sometimes in difficult anatomical landmark patients. We just use roadmap. Sheath management at the time of removal, oftentimes we use vascular closure devices. You can use compression or external compression devices such as the femstop. Um, One of the closure devices that are widely used is called angioseal. The angioseal, you put it over a wire, and then it has a collagen agent that goes above the vessel and seals the arteriotomy. The good thing about angioseal is very easy and easy to learn. The problem with it is you cannot use it with big sheaths. You can only use it with 6, 7, or 8 French sheaths, but you cannot use it in larger vessels than larger arteriotomies than that. Another problem with angioseal is this collagen sometimes instead of being deployed above the vessel or outside the vessel, it goes into the inside of the vessel and it gets into here, and it's a thrombosing agent. It can cause acute thrombosis of the vessel. Another closure device is star close. Star close is it's this basically a star piece. It gets deployed at the outside of the vessel, not the inside. We use star close mostly in vessels that are heavily calcified. If the vessel is very calcified, you shouldn't use angioseal or perclose. Star close is safer because it's deployed outside the vessel and it doesn't interact with the intravascular calcium. Perclose is here. Perclose is probably the widest or the most popular device that's used in the US and I think all over the world. Perclose is a safe, nice device. The good thing about Perclose is you don't lose wire access. So you deploy the suture, it's a suture. You deploy it from here and then you grab it from here and then you tie in the suture around the arteriotomy. And the good thing is the wire is still inside the vessel. So if the vessel is still bleeding, you can deploy or use another perclose, or you can do something else. So you don't lose wire access to the vessel. So I think in our practice we use about 95% perclose. We use about star close angioseal about 5% or less. And important to mention, with perclose, if you are doing a large bore access like a 12, 14 French, 16 French, 20, 24 Frenches, all these big sheaths, you can use multiple perclose in the same vessel. So in a regular basis, in our structural cases, we use at least two percloses, sometimes three percloses in the same arteriotomy, just to close the hole completely and seal it fully. Manual compression after always hold pressure about 2 to 3 times the sheath size. So if you have a 6 French sheath, 6 times 2 is 12. So hold manual compression for 12 minutes. If the patient is on heparin, it's better to hold it times 3. So if it's a 6 French sheath, hold the sheath 18 minutes. And this is how we do with the manual compression. With the arterial access, always hold proximal to the vessel. And with venous, always hold distal because that's where the blood is coming from, and that's how you make the hemostasis. The problem with compression, manual compression, it's painful. You're holding pressure very deep on the patient, and the patient is uncomfortable, and they have to lay flat for at least 4 hours, 6 hours, and so it's very uncomfortable. There is another device that we use, not commonly. It's called FemStop. It's almost like a blood pressure cuff. And so you wrap it around the hip, and then you inflate this balloon that holds basically pressure on the arteriotomy. It's not very effective. You can do it for vessels that are bleeding slightly, not vessels that are bleeding a lot. If the vessel is bleeding a lot, you have to hold pressure manually with your hand. And I cannot stress enough of how important, manual compression is. Um, there's always anatomical requirement for closure devices. They say don't use it in other areas than the common femoral, but in reality, nowadays we've been using it in other vessels. We use it in the axillary subclavian. We use it in the venous system, and we use it also in the SFA if the SFA is big. So if the minimal lumen diameter for perclose, for example, shouldn't be smaller than 4. So if the vessel is smaller than 4 millimeter, you shouldn't put a closure device. Always try to do a femoral angiogram before you deploy a closure device so that you know what the anatomy look like. Closure devices in meta-analyses, and these are old data from at least 10 years ago. Closure devices did not show difference in bleeding. They actually have showed a higher risk of infection and surgery, but patients move and ambulate sooner, and you get hemostasis quicker. But you have to understand that these studies were done before the era of large bore access. Now with large bore access, it's very important to consider using closure devices because it helps with these large bore holes. Clinical scenario here, from several years ago, a patient underwent a diagnostic angiogram from the right femoral access, and they used an angioseal. And at the end of the case, after the patient went to the recovery area, the nurse did not feel the pulse, or she said there was no pulse in the foot, and the patient had a normal pulse before. And as you notice here, the whole external iliac and the femoral is gone. So what would you do next? Things you have to think about, is this a thrombus? You have to give heparin, or is this a closure, an acute closure from the device that you have to go in and open it and put in a stent, or should you refer for surgery? And so what we did is we went from the other side, take a picture from the other side, and you can see here there is an abrupt cut off of blood from here and downwards. And so there's no blood supply all the way down. And so this patient was sent for surgical exploration because it was thought the burden of thrombus is very heavy because there is no restoration of blood supply. If there is a restoration of blood supply downwards, you can sometimes try to intervene percutaneously, but this patient was sent for surgery, and this is what was found in surgery. It was a big clot. It was filling the whole SFA, the tibioperitoneal trunk, and and even the profunda. And what was found in the distal vessel of the SFA, there was this device. And if you remember, this is an angioceal closure device. And so this is the collagen that I told you sometimes collagen can accidentally be deployed inside the vessel instead of outside the vessel. So closure devices have their own issues, so you have to be careful when you are using them. Another case here, patient came in for TAVR because of aortic stenosis, and basically patient was obese. The baseline shots and the CTA suggests, the anatomy is okay, it's favorable. The sticks were okay. It's a little bit low here. You're sticking. They stuck almost at the SFA because the bifurcation is high. But anyways, the stick here in the main axis is okay in the right side. And so they ended up using a 14 French sheath for the TAVR, and they deployed Tupper closes at the end. They gave protamine. They achieved hemostasis, and the patient went to the ICU. And in arrival to the ICU, they did not feel pulses, and they got the PVR, pulse volume recording, and this is how it looked on the right side. And remember, the right side was the axis, the large bore axis, and so the PVR was flat on the right side, suggesting there's an acute occlusion somewhere. And so they decided to do a CAT scan. And if you notice here on the CAT scan in the left picture, there is a blood supply here, there is a blood supply here, but there is nothing here. So the external iliac was cut at some point and occluded, but there was reconstitution probably from the internal iliac here, collaterals to the femorals. So patient was taken for angiogram, and as you notice here, there is a total occlusion in the external iliac. But if you stay on the late phase, this is the late phase here in the right side. You'll notice there's reconstitution of blood here. So you start seeing blood supply here, but this area is occluded. So also interestingly, you can see the horseshoe needle kidney. So the horseshoe needle kidney was just an incidental finding, really not related to this case, but sometimes you'd find these incidental findings. And so what we did in this case is we decided to go in and balloon this area, and you can see this dissection. And probably this was the main reason that propagated the occlusion. And so it starts always like this: a small injury, dissection, and then it causes thrombosis, and then a complete occlusion. And so ballooned, and then went in with a thrombectomy device and basically aspirated the thrombus. And before that, we use embolic protection devices. Always in these acute thrombus, try to use embolic protection devices. They are like baskets that you deploy them very distal in the SFA, so that when you start dislodging the thrombus proximally, the thrombus doesn't travel distally. And if it travels, it gets caught in the basket. And so thrombectomy dealt with it, and then there was a stent, balloon expandable stent in the iliac, and self-expandable stent in the femorals. Again, we've talked about the self-expanding stent and balloon expanding stent in the first lecture, when to use what, and because it's a high flexure point in the femoral, so we use self-expanding stent. And this is a limb salvage a procedure. Otherwise, we hate to put in a stent in the femorals if we don't have to. And this is the runoff of the right femoral of the right lower limb. You can see at the end there is reconstitution and good blood supply throughout the leg and down to the foot. And the patient did very well. And this is the PVR at the end. It improved back to normal. Another thing that happens sometimes is this is a patient where a patient had a very calcified vessel, and after you got the access and you deliver the sheath, it's you can feel sometimes when you push a sheath through a calcified vessel, it's very crunchy, and you have to push really hard. And at the same time, you have to be careful when you pull that sheath out. And this is a braided sheath, if you're familiar with this. Braided sheath is very helpful in heavily calcified vessels because they don't bend and they don't break as easily. But this patient, when they were pulling the sheath out, they were pulling from the head of the sheath instead of pulling both the head and the body of the sheath, and so it ended up separating and was bleeding. So vascular surgery came in. They made a small cut down, and then they took out the sheath out, and then hemostasis was achieved by manual compression. They just made a very small incision to take the rest of the sheath out. So bottom line here, or the point to learn here is these sheaths can break, and so you shouldn't pull too hard on them. If they're stuck, you need to find out what to do next. Either make a small cut down, a small incision, and so that you pull it easier. Risk factors for bleeding. There are a lot of factors that increases risk of bleeding, but we always say old, frail, female, thin ladies. So these old females that are thin and with a low BMI, these have the highest risk of bleeding. Their vessels are just very, very thin, and they can start bleeding easily. Also, obese patients have higher risk of bleeding. The BMI, if you have a BMI of 40 or above, that increases the risk of bleeding quite a bit. Management of bleeding is, as I said, hold pressure. Always call for help. Ask your other colleagues from interventional cardiology, interventional radiology, vascular surgery, whoever you have, and get IV access if you need transfusion. Reverse the blood thinner. If you gave heparin, give protamine, and always hold pressure yourself. Do not depend on anyone else to hold pressure. And one thing I would say is if there is a bleeding and you're concerned of bleeding, a lot of people here the first thing they think about is get a CT to look for retroperitoneal hemorrhage. And this is never the correct answer. Don't go and send the patient to the CAT scan and wait until you get the result back and the patient is bleeding. If you need to do something, you can get access from the other side and take pictures and stop the bleeding by balloon tamponade, but don't send the patient for a CAT scan to look for retroperitoneal hemorrhage. That's usually not the correct answer. Again, if you have retroperitoneal hemorrhage and patient is hypotensive, always think about retroperitoneal hemorrhage with hypotension after vascular access. Again, do not use do not routinely get a CAT scan. Just hold pressure and get IV access and give transfusion, reverse anticoagulation, get appropriate help. You always need help because you're holding pressure on one side. You need your colleague or your friend, your other interventionalist to come in and get access on the other side, the contralateral arterial access, and get a sheath up, take a picture, see what's happening. And so you always will need help. Now, radial access, there was a lot of studies, the Arrival study that showed, significant decrease in vascular complications with radial compared to femoral access. Also, the Matrix study, it showed there is a significant improvement or significantly lower risk of mortality, MI, stroke with radial versus femorals. But, the same thing, there was a big meta-analysis published in JACC Intervention in 2013, about 10 years ago. It showed radial has lower mortality than femoral. We prefer radial always for coronary cases. We always do coronary cases with radials, but remember, if you need bigger sheaths, you need bigger and you're doing a more complex case, you're doing CTOs. Do not shy away from using femoral. Femoral access skills are very helpful. And so these studies probably carry a lot of bias because they also are including patients who are sicker. Usually, patients who had femoral access are usually more complex patients and sicker patients and had more complex coronary disease, and so the mortality might be higher in that population. And so there is some bias, but again, radial is safer. Try using it as much as you can. And this is another British study, and they followed patients for about 10 years, comparing femorals to radials, and they showed that radials is as much lower risk than femorals, and so the same conclusion. This is a similar thing. Radial is better in mortality and major bleeding. So radial, always stick about 1 centimeter above the styloid process. So the styloid process is here, so go above a little bit, and then stick the radial. Use a micropuncture kit. We always use a micropuncture kit. Ultrasound for radial, I don't usually use ultrasound for radial, but it's good to use it. It's good to learn it. It's good to be comfortable with it. It does not take more time. Ultrasound does not delay you more than just blind stick. As a matter of fact, this study showed that if you use ultrasound, you would have less number of attempts, and you will be more successful to get into the vessel with ultrasound quicker than the blind. And there's no big difference in timing. So ultrasound is also helpful for radial access. Radials, they spasm a lot. And so you have to be familiar with that, especially when you do coronary cases with conscious sedations and patients are awake and they are not fully sedated. So use nitro, inject nitroglycerin 200 or 300, or use verapamil. So these are the two agents that we mostly use. Also, sometimes even if you use these things, you still have a lot of spasm, especially females. Females tend to have a lot of spasm. And so mostly because they are anxious and stressed. And so what you have to do is sedate them more. Sometimes we've had cases where we had to intubate patients just because they had severe spasm in the radials and the sheath got very stuck there. It's almost the radial is spasming so hard on the sheath that you cannot move the sheath anymore. You can't even pull out the sheath. So you have to sedate the patients. Also, always remember with radial sheaths, always give heparin. We give about 4,000, 5,000 heparin through the radial sheath, but sometimes you can give it IV as well. I usually give it through the radial sheath. There is specific types of radial sheaths. They are different than femoral sheaths. So here on the left side, this is a 6 French femoral sheath. On the right side, this is a 6 French radial sheath. And if you notice here, the difference is the radial sheath, the 6 French, is much smaller than the femoral sheath because it has a very thin wall. And so both the inner lumen of them are both 6 French, but the wall of the sheath is thinner in the radial, and so that's why the radial sheaths are smaller, although they have the same lumen size. The other thing about the radial sheaths that are different from femoral sheaths is the walls of the sheaths are hydrophilic. So once you put some water or saline on the sheath before you insert it into the radial, it gets very lubricious and becomes easy to insert into the radial artery. Radial access complications, failure to access, that's a common issue, especially if patients have had radial access before. A lot of them, they tend to occlude. So radial artery occlusion is about 10%. Vasospasm is a very common complication or issue with radials, I would say. Hematoma, pseudoaneurysm, dissection, perforations, all of these, we see them with radial. So radial is not completely a very no, it's not a zero risk procedure. There are complications that happen with radial. So prevention of radial occlusion. So to prevent the radial artery from occluding, you have to do what we call patent hemostasis. And what we mean by patent hemostasis is you have to put a TR band, and this is the band that you put here, and then you take out the sheath, and then you inflate the band. It has a balloon inside of it. And then once you stop the bleeding, then you start deflating the balloon slowly until you get a pulse back. So you connect the index finger to a pulse ox. And if you inflated the balloon fully, you will see no waveform in the index finger and the pulse ox. And then you start deflating the balloon slowly. You start deflating until you see a waveform in the pulse ox. And that means there is some flow going through the radial. It's not occluded completely, but it's not bleeding. And that's what we mean by patent hemostasis. And this is what we do for radials. Also, you can do reverse Allen's test to determine if the radial is still open. So basically, put in the balloon in the radial, put in the pulse ox, you have a waveform, and occlude the ulnar, because sometimes you will have a waveform here in the pulse ox, but the waveform is coming because there is a blood flow coming from the ulnar. And so, because remember, the ulnar can have collateral flow to the index. So to make sure that the blood that's coming to the index is from the radial, just put your finger on the ulnar and occlude the ulnar and check the pulse ox. If you still have a good waveform, that means there is a good blood supply through the radial into the index finger. If you lose the waveform, then you have to deflate the radial band balloon more. Some other issues with access, radial access, there's something called aseptic granuloma. Sometimes the radial sheaths, they have, as I said, lubricious hydrophilic coating, and sometimes this coating can cause inflammation. And the treatment for them, we use antibiotics, steroids, and you don't have to always debride them, although some surgeons would do debridement, but you don't have to do that always. This is another complication from radial access. This is as you see the thumb here, you see the blue discoloration. That's an embolus. So always, when you do transradial sheath, always flush it the whole time, because sometimes you can have clots hiding inside the sheath, and these clots will travel distally when you remove the sheath out. These cases, if they happen, you just give them anticoagulation, Eliquis or Xarelto or any oral anticoagulant for a few months, and they would do okay. Sometimes when you are advancing the wire, it can cause small perforations. This patient has a hematoma here. And so when you see this, you would wonder, you accessed in the radial, why would you have a hematoma in the forearm? And this is called an access wire exit. And what happened here is basically the wire exited somewhere here. You were getting in with the radial wire, and the wire in this area, in this bend, it exited and caused perforation. It's usually not a big problem if you still have wire through. If you have a wire through, just complete your procedure, finish whether you're doing a diagnostic or a PCI or whatever. Because if you put a sheath through this over the wire, it would almost act as if you balloon tamponade that perforation. So by the end of the case, you will see that the perforation sealed. But if you discover this late, if you discover it at the end after you took out the wire and the catheters, and then you took a picture and you saw this perforation, then what you need to do is basically um, you have to hold pressure. You have to hold pressure for a long time in the forearm and so this patient he still had access with the wires and sheath. They finished the diagnostic angiogram, and then at the end of the case, they pulled everything out and everything sealed on its own, and there's no residual perforation here. It's just because the catheter throughout the case, what the catheter was going through this and was causing occlusion, almost a balloon tamponade mechanism. Another one is pseudoaneurysm. Pseudoaneurysm can happen. This patient had a PCI and then came back a few days later with a swelling. And as you notice here, the CAT scan, there's a big pseudoaneurysm here. And this is how it looked. And, manual compression works most of the time, but you need a lengthy manual compression and you need to compress really hard. And I have had these issues a few times. And to be honest, I just do this myself. I do not depend on anyone else to do manual compression for these cases. The pseudoaneurysm needs a very lengthy manual compression. I just grab a chair. I sit next to the patient while he's on bed, and I just hold pressure for an hour. A very, very strong manual compression. I just keep talking to the patient about different stuff just to let the time go by. And at the end of the case, all the cases I've had, the manual compression worked very well, and the pseudoaneurysm disappeared at the end. But it doesn't work all the time, especially if the pseudoaneurysm is big. Sometimes, actually, if you do manual compression, it can pop. The pseudoaneurysm can pop, and it can create big bleeding into the subcutaneous tissue. And so, in that case, you have to involve surgery. Always, I would say, always when you have a pseudoaneurysm, talk to surgeons first and let them know that there's this case that came to me. I will do manual compression, but if it fails, I will let you guys intervene. So just give them heads up in case you need them to come in immediately. Another thing you can do for pseudoaneurysm is thrombin injection. You just bring an ultrasound and look where the pseudoaneurysm is. If the neck of the pseudoaneurysm is less than 1 centimeter, so it has a narrow neck, then you can just bring a thrombin and inject it here. You just inject in the pseudoaneurysm space, and the thrombin will basically form a clot in the pseudoaneurysm space. Basically, you are turning that bloody cavity into a clot, and it will dissolve on its own with time. So the problem is if the neck of the pseudoaneurysm is big, the thrombin injection, the thrombin can travel throughout the pseudoaneurysm cavity into the vessel, into the main vessel, and that can cause a thrombus in the main vessel. And that's why you should not inject thrombin if the neck of the pseudoaneurysm is bigger than 1 centimeter. In this patient, it's not my case, but they ended up calling surgery because they held manual compression and they felt that the pseudoaneurysm popped and ruptured and spread and started bleeding more. And so they called surgery. They opened that area and they explored where the bleeding was from. And you see, this is the hole here. This is where the vessel was bleeding, and they just sutured it. As you see, this is a suture, and they closed. In conclusion, think about the anatomy. Always plan ahead of time and know the 3D anatomy and be prepared for the obstacles, unforeseen obstacles that you might encounter. And we described several of these challenges and complications. Use angiogram if you are not sure where things are, and don't just guess and keep pushing things forward. Always use the tools that you have, all the other angiogram, venogram, ultrasound, all these things, and hopefully these messages will help you avoid future complications. Thank you very much. I have a for just for next month, I have a lot of commitment during Ramadan, so I'll skip. We'll have to skip the lecture next month because it will be Ramadan. But inshallah, we'll meet after Ramadan. But I'll keep going. We need to keep going with this course long term, and the plan is to cover the whole cardiovascular field step by step. We have been the past 3 months, we've been talking about peripheral vascular disease, vascular access. Next sessions, I'll be talking about vascular cases. I have a bunch of interesting vascular cases that I wanted to share with you. So we might have to spend one or two sessions going through these cases, and also talk about performing diagnostic peripheral angiogram. The other thing is there's a conference in Riyadh in April. It's called TCT Middle East. TCT conference is a American big prestigious American conference. This year, they will do it in Saudi, in Riyadh. It's going to be the first of its kind, and so it will be a very great opportunity for you to go and learn what people are doing around the world and connect with cardiologists and surgeons في الخليج or even internationally. There are opportunities for the conference. There were case reports and cases. I've helped some people submit cases. Unfortunately, the deadline has ended already. The deadline is still open for they have a section called Shark Tank. It's basically innovative. If you have an innovative idea and you want to apply it, you can submit that idea, and there is a prize on that idea ب 200,000 دولار بيعطوا جائزة للفائز في هذا المسابقة. But anyways, try to attend that conference. And at this point, I'll be open to questions.
ب- It seems no questions. Thank you, Dr. Anas. It was a very comprehensive يعني knowledgeable covered all the axes حقيقة. But you do have questions أحيانا when I'm يعني wondering. You told you are bridging the pseudo aneurysm radial artery for more than 1 hour, and why sometimes not call the surgeon on time and it is a very quick procedures and local anesthesia, the same. You will not add anything. And I think in 20 or 30 minutes, no more. Is it availability of the surgeon or the people don't want to open? And I saw a couple of complication in the femoral. They try to do more, then they call a surgeon. Why not to call on time? And it's a very small incision. The result is good when you suture the opening, the holes. It's very easy procedure and will not take more time. That's my question.
Yeah, I mean, I think you have a point. I think these things happen usually after hours. We always talk to the surgeons. As I said, we always talk to them up front and let them know. And this is a habit that we have. We tell them there's a pseudoaneurysm happening, but we try to avoid surgeries because the patients don't like it. They think of it as a bigger issue and a bigger complication. Although as a surgeon, you think of it as a smaller incision and stuff like that, and I agree. But if the cases I've had myself with manual compression, it resolved. Of course, it does not. Manual compression is not always the solution, and so there are always rules to involve the surgeons. In cases of femoral issues that you saw not involving the surgeons, I think it's just we are we are as a cardiovascular community, even as vascular surgeons in the U.S., we are shifting towards transcatheter approach for as much as we can. So if you call a surgeon for example, for example, that bleeder you saw in one of the branches in the external iliac, or that laceration of the external iliac, the surgeon would do the same thing. They would go in and stent, and so that's kind of becoming the common approach, and so even for surgeons. And so open surgical approach is becoming kind of in these cases, I'm not saying it's always the case, but in these cases, surgical solutions are kind of open surgical solutions are becoming as a second thought, not as the first line thing to do.
Thank you. Please.
I think other things we did not mention the other vascular access sites. The pedal access, posterior tibial access, popliteal access, subclavian carotid access. All of these are vascular access sites that we use in our field as cardiovascular interventionalists or vascular surgeons. But they're less common, so I just did not mention them. But maybe when we mention cases next time, we will briefly talk about the alternative accesses. إن شاء الله ما طولنا عليكم. الوقت متأخر عندكم. أعتذر بس اللخبطة في الجدول، لكن إن شاء الله نظل على تواصل.
ان شاء الله ربنا يعينك حق ما طولتم. ثانك يو والله that you are giving your time. عارفين وقتك. خالص تحية.
الله يحفظكم ويبارك فيكم. يلا تصبحوا على خير.
يلا
تمام.
ربنا يحفظك.
السلام.